Welcome back to the deep dive. Today we are taking on what might be the most complex, high stakes, and frankly intimidating system in the entire human body.
I think you're right.
We are heading right into the command center. We're
Yeah.
talking about the brain and the spinal cord.
It is the ultimate frontier of human anatomy. And honestly, it's the one area that tends to make even seasoned medical professionals a little nervous.
It really is. And I have to admit, just looking at the stack of research, clinical guidelines, and lecture notes we have for today, specifically focusing on these advanced neurological concepts, it is dense.
Oh, it is.
We're talking about intracranial pressure, traumatic brain injuries, spinal cord severing, and some truly bizarre shock states. It feels a little overwhelming just looking at the table of contents.
It can definitely feel that way. I mean, neuro is one of those areas where the anatomy is so intricate, the physiology is incredibly sensitive, and the margin for error is, well, it's razor thin. You can have a patient with a broken femur, and you have some time, you know? You have time to figure things out. But with the brain, seconds matter.
Seconds matter. But if we take a step back, the mission here isn't just to memorize a textbook diagram of the circle of Willis,
No.
or to recite the names of the cranial nerves for a trivia night.
Exactly. The core mission of this deep dive is understanding the clinical application. We are looking at this through the lens of the nurse or the critical care provider at the bedside.
Okay.
Because when you are dealing with the brain and spinal cord, you are dealing with a person's personality, their mobility, their ability to breathe, and their very existence as a conscious being.
And reading through this material, one theme kept just jumping out at me. It seems like the entire philosophy of neurocritical care comes down to one specific battle. It's not necessarily fixing the crash that happened.
No.
It's about what happens next.
That is the absolute golden rule of neuronursing. We have to distinguish between the primary injury and the secondary injury.
Let's break that down because that sounds like a really vital distinction.
It's everything. The primary injury is the event itself.
The moment of impact.
The moment of impact, the car crash, the fall from the ladder, the blow to the head with a baseball bat, that mechanical damage, the shearing of axons, the bruising of tissue, the crushing of bone has already happened by the time the patient rolls into the ER or the ICU.
So you can't go back in time.
It's irreversible. You
Yeah.
cannot unring that bell. The damage is done.
Okay.
But the secondary injury, that is the battleground. The secondary injury is the cascade of events that follows. The swelling, the bleeding, the lack of oxygen, the chemical changes. That is progressive. It doesn't happen all at once. It evolves.
It unfolds over time.
It unfolds over hours, and it often peaks around 72 hours after the initial injury, and that is what actually kills the patient or leaves them with permanent deficits.
So the nurse's role, essentially, is to stand guard and just prevent that secondary injury from destroying what's left.
Precisely. You are the wall between the patient and that physiological cascade. You aren't just watching monitors. You are actively fighting a war against swelling, ischemia, and hypoxia.
That is such a powerful way to frame it. So let's unpack the biggest weapon in that war. We need to talk about pressure.
The pressure cooker.
Yes.
Yeah.
Intracranial pressure, or ICP.
Yeah.
The source material talks a lot about the Monroe-Kelly doctrine. It sounds very academic, very fancy, but what does it actually mean in practice?
It sounds complex, but it's actually a pretty simple physics problem.
Okay.
Think of the skull as a rigid box. It's bone. It doesn't stretch. It doesn't expand like your stomach does after a big meal.
Right, it's a fixed volume.
A completely fixed volume. And inside that rigid box, you only have room for three things: brain tissue,
The brain itself.
blood,
Right.
and cerebrospinal fluid, or CSF.
Okay, so brain, blood, and CSF. That's the entire inventory.
That's it. And the Monroe-Kelly doctrine simply says that the total volume inside that box must remain constant. So if you add something new, like a pool of blood from a hemorrhage,
A bleed.
or if one component swells, like the brain tissue itself from edema, something else must leave to make room.
Because the skull isn't giving an inch. It's a zero-sum game.
Correct. So the body has these brilliant built-in compensation mechanisms.
Like safety valves.
Exactly like safety valves. If the brain starts to swell, the body first tries to shunt CSF down into the spinal canal to get it out of the skull,
Okay, so it displaces the fluid?
pushes the fluid out, then it tries to squeeze venous blood out of the skull to lower the volume even more. It's a very delicate balancing act.
But there has to be a limit to that, right? You can only squeeze out so much fluid before you just run out of space.
Precisely. And we call that the tipping point, or decompensation. Once you've exhausted those safety valves, once the CSF is squeezed out and the veins are compressed, any tiny, tiny increase in volume causes a massive spike in pressure.
It's no longer a gradual thing.
No, the curve goes almost straight up. The pressure skyrockets.
What kind of numbers are we talking about here? What's normal and what's no?
Normal ICP is roughly 5 to 15 millimeters of mercury. Once we start creeping up past 20, we're in the danger zone. That's usually when we have to start treatment.
So 20 is the magic number.
It's our action threshold. And if it keeps going, we risk the ultimate catastrophe, which is herniation.
We are definitely going to get to herniation, which sounds absolutely terrifying. But before we get there, how does a nurse know this is happening?
Right.
If I'm standing at the bedside, I can't see the pressure inside the skull unless they have a monitor, bolted into their head.
Which some of them do.
Right. But if they don't, what is the very first clue that the pressure is rising?
If you take nothing else away from this section, remember this. The earliest and most sensitive indicator of increasing intracranial pressure is a change in the level of consciousness, or LOC.
Not the blood pressure, not the pupils.
Not initially, no. By the time the pupils change, you are way down the road. You're in serious trouble. It's the behavior. It's the awareness. Think about it. The brain is the most oxygen-hungry organ in the body. The cortex, the part that makes you you, is incredibly sensitive to blood flow.
And when pressure goes up?
Blood flow goes down. The cortex gets hypoxic, and it's the first part of the brain to show signs of distress.
So how does that manifest? What am I actually seeing?
The patient gets restless.
Just fidgety.
Fidgety, confused. Maybe they were cracking jokes with you an hour ago, and now they're just quiet. Or they're picking at their sheets.
Oh, it's a classic one.
A classic sign. Or they don't know what year it is. Or they're just slightly agitated, and you can't figure out why.
So not acting right is actually a legitimate critical clinical finding.
It is a critical clinical finding, and I will tell you, never, ever ignore a family member who says, he just doesn't seem like himself. That is your red flag. That is the cortex screaming for oxygen.
That's a great point. The family knows them best.
Always listen to the family.
Okay, so that's the earliest sign. What about the other signs? The source material mentions headaches and vomiting, but it describes them in a very specific way.
Yes. This isn't your typical tension headache. An ICP headache is often described as continuous, and it gets worse with movement or straining, anything that increases that internal pressure, like coughing
Okay.
and the vomiting. It's often projectile.
Projectile, like in the movies. The Exorcist style.
Sometimes, yes, it can be that dramatic. And what's interesting is it's usually not preceded by nausea.
No warning at all.
It's just boom, vomit. That's because the pressure is pushing directly on the vomiting center in the brainstem. It's a mechanical trigger, not a stomach bug.
That is a very distinct image. Okay, so those are the warning shots. But what happens when the body loses the battle? When compensation fails completely? We see something called Cushing's triad. This sounds like we are in big trouble.
If you see Cushing's triad, the patient is in dire, dire straits. This is a late sign.
So we've missed the early window.
We have. It means the brainstem is being compressed. The body is in a desperate last-ditch panic to get blood to the brain.
So what are the three parts of the triad? What do I look for?
First, you have systolic hypertension with a widened pulse pressure.
Let's break that down. Widened pulse pressure, what does that mean?
So normally your blood pressure might be, say, 120/80. The pulse pressure is the difference between those two numbers, which is 40.
Okay.
In Cushing's triad, the top number shoots up, maybe to 180, 200, 220. But the diastolic, the bottom number, stays relatively the same or even drops. So you get a pressure like 200/60. That gap is huge. It's widened.
Why does that happen?
The heart is pounding harder and harder, trying to force blood into that high-pressure skull. It's like a battering ram.
Okay, so the heart is acting like a battering ram to get blood into the brain. That's one. What's the second?
Bradycardia, a slow heart rate.
Now that seems completely counterintuitive.
Mm.
Usually when the body is in crisis, the heart races. You get tachycardic.
Exactly. But here, the body's baroreceptors, the pressure sensors in the big arteries, detect that massive blood pressure spike we just talked about.
Right. The 200/60.
They scream, whoa, BP is way too high. And they signal the heart to slow down to try and compensate. So you have this bizarre paradox, screaming high blood pressure, but a slow, thumping heart rate.
That's a huge red flag.
A massive one.
And the third piece of the triad.
Irregular respirations. We might see something called Cheyne-Stokes breathing.
Can you describe that?
Yeah, it's a pattern where they breathe really deep and fast, then more and more shallow, and then they stop completely for a few seconds, an apnea period. and then it starts all over again.
And what does that tell you?
It tells us the pressure is crushing the respiratory centers in the brainstem and the medulla. The most basic life-sustaining functions are failing.
So, high blood pressure with a wide gap, slow heart rate, and weird breathing. That is Cushing's triad. And that leads us to the nightmare scenario you mentioned earlier, herniation.
Herniation is exactly what it sounds like. Tissue is being forced out of its normal compartment and into another.
It's squeezing through a space it doesn't belong in.
Exactly. And in the brain, this usually means the brain tissue is being pushed down through the opening at the base of the skull, the foramen magnum.
That's the only exit.
It's the only way out. And what sits right there, perfectly positioned to be crushed, the brainstem. Herniation crushes the brainstem.
And the brainstem controls, well, everything. Breathing, heart rate, consciousness.
Everything vital. When herniation happens, that's when you see the classic blown pupil.
One pupil gets big and doesn't react.
Correct. It becomes fixed and dilated because the third cranial nerve, which controls the pupil, is being compressed as it passes by the brainstem.
And what else?
You see posturing decerebrate, where the arms are extended and rigid, or decorticate, where the arms are flexed in towards the core.
Those are terrible signs.
They are. And eventually you lose the brainstem reflexes entirely. No gag reflex, no cough reflex. It is essentially incompatible with life if not reversed immediately.
So let's talk about reversing it, or at least preventing it. We are the nurse at the bedside. The pressure is creeping up. What are our weapons? What interventions do we have in our arsenal?
We go right back to the Monroe-Kelly doctrine. We need to make space.
Okay.
So, first and simplest, positioning. We elevate the head of the bed, HOB, to about 30 degrees.
Why 30 degrees?
It uses gravity to help the venous blood drain out of the skull. It's a simple, passive way to lower pressure. But, and this is key, we must keep the head in a neutral position.
Neutral means looking straight ahead, no tilting.
Exactly. Looking straight ahead. No bending the neck to the side, no extreme flexion where the chin is on the chest. Think of the jugular veins as the drain pipes for the brain.
Okay.
If the neck is twisted or kinked, you're stepping on those drain pipes. Blood can get in, but it can't get out. That just backs everything up and increases pressure.
That makes total sense. Keep the pipes open. What about oxygen?
Vital. Absolutely vital. Two things are the brain's enemy here. Hypoxia, which is low oxygen, and hypercapnia, which is high CO2.
And why are they so bad for ICP?
Because they are potent cerebral vasodilators.
Vasodilators make the blood vessels bigger.
Right. And if the arteries in the brain get bigger, they take up more space in our fixed box.
Which increases pressure.
Correct. When CO2 levels rise in the blood, the cerebral arteries automatically dial open to try and get more oxygenated blood flow. It's a protective mechanism that backfires here.
Oh, so what's the goal?
The nurse's job is to maintain the PaO2, the oxygen level in the blood, greater than 100 millimole Hg, and maintain normal CO2 levels. We definitely don't want them retaining CO2.
Okay, positioning, oxygen, and I saw some heavy-hitting medications in the notes. Mannitol and hypertonic saline. These are not your everyday Tylenol.
No, these are chemical weapons against brain swelling.
Let's start with mannitol. What is that?
Mannitol is an osmotic diuretic. It's a type of sugar that we give IV, and it essentially pulls fluid out of the brain tissue and into the blood vessels.
So it dehydrates the brain.
It literally dehydrates the swollen brain cells. Then the kidneys can just pee out all that extra fluid.
And hypertonic saline. The notes called it a salt bomb.
That's a good way to describe it. It's usually 3% saline, which is much, much saltier than your normal blood.
And how does that work?
It works on the simple principle of osmosis. Water follows salt. So we make the blood really salty, and it sucks the excess water right out of the swollen brain cells.
Like a magnet for water.
Exactly. It's very effective, but you have to monitor their sodium levels very closely because you can make them too salty, which causes its own set of problems.
A delicate balance.
Always.
And finally, there's just the management of the environment, right? The little things. We don't want to overstimulate these patients.
Correct. We have to avoid what we call clustering care.
What does that mean?
You know, typically nurses are taught to be efficient. Go in, do the vitals, suction the patient, turn them, change the sheets, do the neurocheck all at once, and then leave so the patient can rest.
Right. Get it all done.
But for an ICP patient, doing all of that at once creates a massive cumulative spike in pressure. Each activity adds a little bit of stress, a little more pressure.
So you have to space things out.
You space it out, you do one thing, let them recover. You minimize suctioning as much as possible because coughing violently spikes ICP. You keep the room quiet, Keep the lights low. We are trying to keep the brain completely calm.
It's a very delicate dance. You have to monitor them closely, but you can't bug them too much.
That's the art of neuronursing right
All
there.
right, let's pivot slightly. We talked about the pressure, but let's talk about the injury itself. Traumatic brain injury, or TBI. The sources break this down into different types and trajectories. First off,
Yeah.
just how does the injury actually happen, the physics of it?
Right, the physics. We generally talk about two main mechanisms. Acceleration injuries, that's like a baseball bat hitting a stationary head. The head is forced to accelerate rapidly.
Yep.
And then deceleration injuries, which are more common. Think of a car crash where your head hits the windshield, the skull stops, but the brain, which is floating in CSF, keeps moving forward until it slams into the inside of the skull.
And the term coup contre coup comes up a lot with that.
It sounds fancy French because it is. Coup is the initial impact, the brain hitting the front of the skull.
It's a primary hit.
Right, but then the brain bounces off the front and rebounds, hitting the back of the skull. That's the contre coup. So you get bruising and damage on both sides of the brain from one single impact. It's a slosh effect.
Ouch. Now, bleeding is a major concern with these traumas. The notes distinguish between three main types of hematomas, or bleeds: epidural, subdural, and intracerebral. I really want to clear these up because they present so differently. Let's start with the epidural hematoma.
The epidural hematoma is the classic talk and die scenario.
Talk and die. That's an ominous name.
It's terrifying. This bleed happens between the dura, which is the tough outer covering of the brain, and the skull itself.
On top of the dura.
Epidural, yep. And it's usually caused by an arterial tear, often the middle meningeal artery, which runs in a groove on the inside of the skull.
And arterial means high pressure, fast bleeding.
Exactly. Arteries bleed fast and hard. But the presentation is what catches people off guard and makes it so dangerous. Typically, the patient gets knocked out at the scene of the accident.
Okay, brief loss of consciousness.
Right. But then they wake up, they have what's called a lucid interval. They might talk to you, say they're fine, maybe just have a headache. They might even refuse to go to the hospital.
So everyone thinks they dodged a bullet, they're okay.
Right. But meanwhile, that torn artery is pumping blood into the skull, rapidly expanding the hematoma and compressing the brain. Then suddenly, sometimes an hour or two later, they crash. Rapid decline, a blown pupil, coma.
That is why you never just send someone home immediately after they've been knocked unconscious, even if they seem fine.
Exactly. It is a true surgical emergency. They need to go to the OR to have that blood evacuated.
Okay, so that's the fast one. Contrast that with the subdural hematoma.
A subdural is a bleed between the dura and the next layer in, the arachnoid layer. This is usually venous. It comes from the tearing of the bridging veins that cross that space.
And veins are low pressure.
Low pressure, they bleed much slower. So this is the slow burn.
So symptoms might not show up right away.
Correct. We classify them by time. An acute subdural is within the first 24 to 48 hours. A subacute is from 2 days to about 2 weeks.
And then there's a chronic one.
Right. Then you have chronic subdural hematomas, which can present weeks or even months after what seemed like a very minor head bump.
And the notes mention this is really common in the elderly and in people with chronic alcoholism. Why is that?
It's because of brain atrophy. As we age, or with chronic alcohol use, the brain actually shrinks slightly inside the skull.
So there's more space.
There's more space. And that stretches those little bridging veins between the brain and the skull. They become tight like little guitar strings.
So they're more fragile.
Much more fragile. A minor bump, something they might not even remember, can tear one of those veins, and it just slowly leaks over weeks.
And because it's so slow, the body kind of adjusts.
For a while, yes. The patient might just seem a little more confused than usual, maybe a bit wobbly on their feet, more forgetful. It can mimic dementia or a stroke, but it's actually a collection of old blood pressing on the brain that can often be drained.
Fascinating. And the third one, intracerebral hematoma.
That's bleeding deep inside the brain tissue itself, the parenchyma. It's essentially a hemorrhagic stroke that's caused by trauma.
So it's not on the surface, it's in the middle.
Right. And this is very hard to treat surgically because you'd have to cut through healthy brain tissue to get to the clot. So for these, it's mostly medical management, control the blood pressure, manage the ICP, and wait for the body to hopefully reabsorb it.
Right. Now, not all TBIs involve these massive bleeds. Some are more. Diffuse. Let's talk about concussions and then the really scary one, diffuse axonal injury.
A concussion is a mild traumatic brain injury, but mild is a clinical term, not necessarily how it feels to the patient.
It doesn't feel mild.
Not at all. It's a transient disruption of neural activity. Structurally, the brain looks fine on a CT scan. There's no bleed, no bruise.
But the patient definitely feels it.
Oh, absolutely. The headache, the amnesia for the event, the brain fog, the sensitivity to light and sound. The key management here, and we're learning more about this every year, is brain rest.
And that's hard for people today, isn't it?
It's incredibly hard. It means no screens, no phone, no TV, no video games, no reading, no intense exercise. You have to let the metabolic crisis that happened in the brain cells just calm down and resolve.
And the risk if they don't,
Yeah.
if they go back to play too soon.
The big fear is second impact syndrome. If you get another concussion before the first one has fully healed, the brain can swell massively and catastrophically. It has a 50% mortality rate in young athletes.
Wow.
And long-term, of course, we worry about CTE, chronic traumatic encephalopathy, from repeated hits over a lifetime.
Now, diffuse axonal injury, or DAI. This sounds much, much worse than a concussion.
It is devastating. It is one of the worst brain injuries you can have.
So what's happening?
Imagine the brain twisting violently inside the skull during a high-speed rollover crash. This shearing force literally tears and stretches the axons, the long connecting wires of the brain cells. It's microscopic damage, but it's widespread.
So a CT scan might not even show it.
A regular CT scan might look shockingly normal because there's no big bleed to see. But the patient is in a deep coma. The family is looking at a normal scan and a comatose patient, and it's so hard to reconcile.
And the notes say 90% of severe DAI patients remain in a persistent vegetative state.
Yes. The wiring of the brain has been disconnected on a global scale. The gold standard for diagnosis here is an MRI, which is more sensitive and can see those microscopic tears, but the prognosis is very, very poor. It's one of the saddest diagnoses we have to give.
That is heavy. But moving on, the brain isn't just dealing with the initial injury. There are complications that nurses need to watch for in the hours and days following a TBI. The nursing watch list, if you will.
Absolutely. The secondary injuries. And two big categories pop up here: electrical storms and fluid wars.
I like that. Let's start with the electrical. Seizures.
Seizures are very common after a TBI. You have scar tissue, inflammation, blood, all of which are very irritating to the neurons. They become hyperexcitable and can start firing uncontrollably.
And can this happen right away?
It can happen immediately, what we call an early post-traumatic seizure, or it can happen days later, sometimes even years later.
So if I'm the nurse and my TBI patient might have a seizure, what am I doing?
You're instituting seizure precautions. That means pads on the side rails so they don't injure themselves if they start to convulse, having suction ready at the bedside because they might vomit or have increased secretions, making sure an airway is available.
And if they do have a seizure?
Your number one job is safety. Turn them on their side to protect the airway. Don't put anything in their mouth. That's an old dangerous myth.
Right.
Just protect their head, loosen any tight clothing, and time the seizure. Note what it looked like and how long it lasted.
And what about drugs? How do we treat them?
To stop an active seizure, we use benzodiazepines, like IV lorazepam or diazepam. They're fast-acting. And we often put TBI patients on prophylactic or preventative meds like phenytoin, which is Dilantin, or levetiracetam, which is Keppra, for at least the first 7 days to prevent them from happening.
Okay, so that's the electrical storm. Now the fluid balance wars. This part of neuro always trips people up. We're talking about the pituitary gland getting damaged, right?
Correct. The pituitary is the master gland. It hangs right off the base of the brain on a delicate stalk, which makes it very vulnerable in a TBI.
And it controls ADH.
It releases ADH, antidiuretic hormone. ADH's only job is to tell your kidneys to hold on to water. In TBI, the system can break in two opposite ways.
Okay, so we have two extremes, diabetes insipidus, DI, and SIADH.
Let's start with DI. A good way to remember this is dry inside.
DI, dry inside. Got
The
it.
pituitary gets damaged and stops making ADH. The signal to the kidneys to hold on to water is gone, so the kidneys just open the floodgates.
So the patient starts peeing a huge amount.
A shocking amount. We're talking 200, 300, 500 milliliters an hour, sometimes liters an hour.
And the urine is really clear.
It looks like water, crystal clear, very dilute. But because they are losing all this free water, their blood becomes very concentrated, they get dehydrated, and they get hypernatremia, a dangerously high sodium level.
So DI equals dry inside, high urine output, high sodium. What do we do?
We have to give them fluids, lots of fluids, to replace the massive loss. And we give them synthetic ADH, which is a drug called desmopressin, or DDAVP. It's a hormone replacement.
Okay, now let's flip the coin. SIADH.
Syndrome of inappropriate ADH. For this one, think soaked inside.
SIADH soaked inside. Okay.
In this case, the pituitary goes haywire and releases too much ADH. The signal to hold water is stuck in the on position.
So the kidneys stop making urine.
They slow down to a trickle, the urine output drops drastically, and the little bit they do make is very dark and concentrated. And because the body is retaining all this free water, the blood becomes very diluted.
So you get the opposite of DI.
The exact opposite. You get hyponatremia, a dangerously low sodium level, and low sodium is terrible for the brain because it causes cerebral edema, brain swelling. It makes the original brain injury worse. It can cause confusion and even seizures.
So SiADH equals soaked inside.
Hmm.
Low urine output, low sodium. And the treatment has to be the opposite too.
It is. The primary treatment is fluid restriction. We have to stop putting water in. Sometimes we have to restrict them to less than a liter a day, which is very difficult for them. And in severe cases, we might give them hypertonic saline, that salt bomb again, to slowly bring their sodium back up.
It is just amazing how the brain controls literally everything, even how much we pee.
It connects to everything. The whole system is interconnected.
Which is the perfect transition to the connector itself,
Yeah.
the spinal cord. We are moving down from the cranium to the spine.
The information superhighway.
So similar to the brain, we have primary and secondary injuries here too, right? That same concept applies.
Yes, absolutely. The primary injury is the fracture of the vertebra or the compression of the cord at the moment of impact. But the secondary injury, the edema, the inflammation, the swelling of the cord is critical.
And the cord is in a tight space too.
It's inside a tight, bony canal. If it swells, it strangles itself. It loses its own blood supply. That's why we always say you cannot determine the final prognosis of a spinal cord injury immediately.
That must be so agonizing for families.
It is. They want to know, will he walk again? And the honest answer on day one is, we don't know yet. We have to wait for the swelling to go down, which can take up to 72 hours or more.
Let's talk about the anatomy. The level of the injury dictates everything. We have cervical, thoracic, and lumbar. Let's break down the implications of each, starting from the very top, in the neck.
Okay. The higher the injury, the more function you lose. The cervical spine, or C-spine, is the neck. Injuries here generally result in quadriplegia or tetraplegia paralysis of all four limbs.
And there's a famous rhyme about C4.
There is. Every nursing and medical student learns it. C3, 4, and 5 keep the diaphragm alive.
Keep the diaphragm alive.
The phrenic nerve, which is the nerve that controls the diaphragm muscle for breathing, comes out of the spinal cord at the C3 to C5 levels.
So if you have an injury at C4 or above,
the patient cannot breathe on their own. The signal from the brain to the diaphragm is cut. They are ventilator dependent for life.
That is a critical assessment point. If a patient with a high neck injury starts struggling to breathe, you need to act fast.
Immediately. Moving a little further down, an injury at C6 or C7 might spare some arm and wrist function. They might be able to use a specialized wrist-driven grip called a tenodesis grip to hold things. That makes a huge difference in their potential for independence.
Then we hit the thoracic spine, T1 to T12, the chest area.
Right. An injury here causes paraplegia. The arms are completely spared. The issues here are paralysis of the legs and loss of trunk stability and abdominal muscle control.
And you mentioned landmarks for these.
Yes, we use dermatomes, those skin maps. Two key landmarks. T4 is generally at the level of the nipple line, and T10 is at the umbilicus, or the belly button.
And those are super useful for nurses doing an assessment.
They are essential for checking the sensory level. If a patient comes in and says they can feel you touching them at their nipple line but not at their belly button, you know the injury is likely somewhere between T4 and T10.
And then lumbar and sacral, the lower back.
This affects the legs and, critically, bowel, bladder, and sexual function. We always check for the saddle area sensation, the parts of you that would touch a saddle. That's S3 to S5. Loss of sensation there is a red flag for cauda equina syndrome, which is compression of the nerve roots at the very bottom of the spine. It's a surgical emergency.
So we have the anatomy. But when a patient first comes in with a spinal injury, they often go into shock. But the source material highlights a massive point of confusion here. There are two types of shock that sound similar but are totally different: spinal shock and neurogenic shock. Please, help us clear this up.
This confuses nursing students, residents, even attendings all the time. But let's simplify it.
Please.
Spinal shock is electrical. It has nothing to do with blood pressure or circulation. It is a temporary concussion of the spinal cord. Everything below the level of the injury just shuts down.
So what does that look like clinically?
It looks like flaccid paralysis.
Wow.
The limbs are limp, like a rag doll. There are no reflexes, no sensation. The cord is in a state of stunning electrical silence.
And it's temporary.
It is temporary. It can last for days to months. We know it's starting to resolve when reflexes below the injury begin to return. Often they return as spastic or hyperactive reflexes.
Okay, so spinal shock equals electrical silence. Flaccid paralysis, temporary. Now let's talk about neurogenic shock.
Neurogenic shock is hemodynamic. It is about circulation. It is a type of distributive shock, a circulatory collapse, and it typically happens with injuries at T6 or higher.
Why T6? What's special about that level?
That's where a large portion of the sympathetic nervous system outflow is located. The sympathetic system is your fight or flight response. It's what keeps your blood vessels clamped down to maintain blood pressure and keeps your heart beating strong and fast.
So in a high spinal injury, you cut the connection from the brain to that system.
You sever it. The brain can no longer tell the vessels below the injury to constrict, so you lose all sympathetic tone. The parasympathetic system, the rest and digest system, takes over completely unchecked.
And what's the result of that?
Massive, widespread vasodilation. All the blood vessels in the body relax and open up, all the blood pools in the extremities, and the blood pressure tanks.
So you get severe hypotension.
Severe hypotension. But here's the kicker, and this is the hallmark sign that separates it from all other types of shock. Bradycardia, a slow heart rate.
Which is so weird, right? Usually when you go into shock, like from bleeding out, your heart races to compensate. You get tachycardia.
Exactly. In hemorrhagic shock, your BP is low and your heart rate is high. In neurogenic shock, your BP is low and your heart rate is also low because you've lost that sympathetic drive to the heart that would normally speed it up.
Hypotension plus bradycardia equals neurogenic shock. That is the exam question right there.
It really is. And the treatment is different. You give fluids, yes, but you have to be cautious not to cause fluid overload. You often need medications like atropine to bring the heart rate up and vasopressors like norepinephrine to chemically clamp those vessels back down.
That is crystal clear. Spinal is electrical, neurogenic is plumbing.
Perfect way to put it.
Now let's move to perhaps the most dramatic and life-threatening long-term complication of spinal cord injury. This is something every nurse needs to know because it can happen years after the initial injury. Let's talk about autonomic dysreflexia.
This is a true medical emergency, and it only happens in patients with injuries at T6 or higher, and only after spinal shock has resolved.
So what is happening here? The way it's described, it's like the body is fighting a civil war with itself.
That's a great analogy. The communication lines are down, and the two halves of the body are doing opposite things. It all starts with a noxious or irritating stimulus that happens below the level of the injury.
And noxious can mean painful, but the patient can't feel pain there.
Right. They can't feel it, but their body reacts to it. The most common culprit, by far, is a distended bladder.
So their catheter is kinked or clogged.
Exactly. Or the second most common is constipation or a bowel impaction. But it can also be something as simple as tight clothing, a wrinkle in the bed sheets, or a draft from an open window.
Okay, so you have the trigger. What's the reaction?
The body tries to send a pain signal up the spinal cord. It hits the roadblock at the injury and gets blocked. It can't reach the brain. But the local reflexes below the injury go absolutely haywire. They trigger a massive, uncontrolled sympathetic surge.
So all those vessels below the injury clamp down.
They vasoconstrict like crazy, and the blood pressure skyrockets. I mean, massive hypertension, 200 over 100, 250 systolic. It can cause a stroke or a seizure.
So that's what's happening below the injury. What's happening above?
The brain, through the baroreceptors in the neck, detects this dangerously high blood pressure. It says, whoa, this is bad, and it tries to compensate. It sends a signal down to slow the heart rate and dilate the blood vessels.
But that signal is blocked too.
It is. It can't get past the injury. So it only works on the parts of the body above the injury.
So you have two different bodies almost.
Exactly. Above the level of injury, the patient is flushed, they're sweating profusely, their nose might get stuffy, and they have a slow heart rate, that bradycardia again. Below the injury, they are pale, cool, and have goosebumps.
And the main symptom the patient will complain about.
A sudden, throbbing, pounding headache from that severe hypertension.
So the signs are that headache, the crazy high BP, sweating and flushing above the injury, and a slow heart rate. I'm the nurse. I walk in, I see this. What is my first immediate action?
Sit the patient up.
Just sit them up. That's the first thing.
Immediately. Before you even take the blood pressure again. Elevate the head of the bed to 45 or even 90 degrees. This uses gravity to cause orthostatic hypotension. It helps pool the blood in the legs and can bring the pressure down in the brain very quickly. It's a simple, life-saving first step.
Okay, I've sat them up. Then what?
Then you have to play detective. You have to find and remove the stimulus,
The trigger.
the trigger. Start with the most likely suspect, the bladder. Check the catheter for kinks. Is the bag full? If they don't have a catheter, do a quick bladder scan. If they're full, you need to catheterize them immediately, but use some lidocaine jelly so the act of catheterizing doesn't make the problem worse.
And if it's not the bladder?
You move to the bowels. Check for an impaction. Again, use an anesthetic lubricant first. While you're doing that, loosen any tight clothing, check for wrinkles in the sheets, take off their shoes if they're on. You're just trying to find what's bugging the body.
And once you find it and fix it,
The blood pressure usually comes crashing back down to normal almost instantly.
and if it doesn't?
Then, and only then, do you administer fast-acting antihypertensive medications. But 9 times out of 10, it's a plumbing issue that you can fix.
That's incredible. Let's round out our discussion with a broader picture of nursing care, rehabilitation, and teaching. These are lifelong conditions.
They are. In the acute care phase, right after the injury, the absolute priority is immobilization.
Don't make it worse.
Don't make it worse. Keep the spine in a neutral alignment. That's where log rolling comes in, moving the patient's entire body as one single unit to prevent any twisting of the spine, and careful C-collar care.
Respiratory care is huge too, especially with those cervical injuries.
Huge. We do what's called assisted coughing or quad coughing, where the nurse provides a firm push on the diaphragm to help the patient generate enough force to clear secretions. Chest physiotherapy, suctioning, all vital.
And cardiovascular.
DVT prophylaxis. Blood clots. When the leg muscles aren't contracting, the blood just pools down there and clots very easily, so they'll be on blood thinners and wear compression stockings.
And long-term rehab. This is where the nurse becomes a teacher.
Absolutely. So much of it is teaching. You are teaching them how to manage a neurogenic bladder and bowel. That means teaching them clean, intermittent self-catheterization on a schedule, or how to manage a bowel routine with suppositories and digital stimulation to prevent constipation and impaction.
And skincare is a constant battle.
A constant battle. They can't feel pain or pressure, so they don't get the signal to shift their weight. They can develop horrific pressure injuries, so we teach them to do weight shifts in their wheelchair every 15 to 30 minutes.
And then there's the psychological aspect, which is enormous.
It's life-altering. You're addressing grief, depression, changes in body image, sexuality, and helping them plan for a future that looks very different than what they imagined. It's truly holistic care. And of course, prevention teaching seatbelts, helmets, not diving into shallow water.
Finally, we have to touch on the end of the line. Brain death. When all else fails.
It's a very difficult but very important concept. It is the legal and clinical definition of death. It's the irreversible cessation of all brain function, including the brainstem.
And there are very strict criteria for this.
Very strict. The patient must have a GCS of 3, the lowest possible score. They must have no brainstem reflexes, no pupillary response, no doll's eyes reflex, no cold calorics, no corneal gag or cough reflex.
And the final test.
The apnea test. We disconnect the ventilator and see if their CO2 level rising in their blood triggers them to take a breath. If the CO2 rises above 60 and they still make no effort to breathe, that confirms the absence of brainstem function.
And the nursing role in that moment.
It shifts. It becomes about supporting the family through an unimaginable tragedy. And if they choose donation, it becomes about organ preservation, maintaining blood pressure and oxygenation to keep the organs viable for transplant. You are caring for the patient's final gift.
We have covered an incredible amount of ground. Let's try to recap.
I think we can boil it down to the big 3 high-yield topics. Number 1, ICP management. Remember the Monroe-Kelly box brain, blood, CSF, and that your first sign of trouble is a change in LOC.
Number 2.
TBI differentiation. Know the difference between an epidural hematoma, the fast arterial talk and die, and the subdural hematoma, the slow venous slow burn.
Yeah, number 3.
The spinal cord emergencies. No neurogenic shock low blood pressure, ANDI low heart rate, and no autonomic dysreflexia sky-high blood pressure, a slow heart rate, and a pounding headache. And your first move is always to sit them up.
That's a perfect summary. So a final provocative thought to leave our listeners with.
The brain uses 20% of the body's oxygen, but it has no way to store energy. It lives second to second. It is the most powerful and complex thing we know of, yet it is incredibly fragile.
And the nurse's role in that.
The nurse becomes the external cortex for the patient. You are the one monitoring the pressures, the flows, the oxygen, the CO2, all the things that the damaged brain can no longer regulate for itself.
So you're telling us to look at our neuroassessments not as a list of checkboxes, but as looking into the black box of the central nervous system.
You're not just checking a box. You're protecting a mind.
A powerful thought to end on. Thanks for listening to The Deep Dive.